here. Thank you all for joining us. So I'd love to go ahead, audience members, introduce yourself in the chat. I love a lively chat. I love multitasking. I am so excited to welcome you all today. My name is Jessica Halem. I use she and her pronouns. I'm the senior director here at ADOS. I get to work with an incredible team here in Philadelphia. So shout out, here I am in Philly. We're going to dive in today. Our hope in this conversation, I'll tell you very selfishly, was to influence our work. So our first priority here at ADOS was to really gather together people that we love and admire and work with to have a rich conversation as we dive into this work of cultural competency training. I have been providing cultural competency training one way or another for over 20 years. I'm anxious to reinvent, reinvigorate, rethink this subject. I hope that all of you in the chat will help us do that as well. We also have the Q&A open, and again, we can use all of the Zoom tools. But let's dive in. What we're going to do today is I'm going to talk a little bit about. I'm going to talk a little bit. Look at me, I did it. Oh my gosh, Jessica Halem, 3 years into this, and I did it. Oh gosh. The first rule of cultural competency training is being able to use Zoom. I would say that. So listen, what I first wanted to do today was talk to you a little bit about ADOS. This is our inaugural public event. I've been here since June. Our fearless leader, Dr. Jose Bauermeister, launched in early 2022. And this was our chance to talk a little bit about who we are and why we picked this topic. So let me dive in a little bit and talk a little bit about ADOS. There's our fearless leader, Jose Bauermeister. Everyone wave at him. But again, part of Jose's thought and bringing together us as a team was to bring together, and what we're doing today as an event, bringing together these experiences of both those in the community, thought leaders, public health science. We want to bring together people who work in multiple sectors. So we are really interested, you'll see in this next fancy slide, we're really interested in building bridges, learning from those who are working in policy arena, government, healthcare, and business. So today we've got leaders in the startup space, policy arena, as well as research to try to learn from each other. Why did we pick this topic? Why is talking about LGBTQ competence such a vital topic in health and healthcare? We could talk about it from an educational standpoint. We could talk about it from a policy standpoint. Here in healthcare, this is some numbers that many of you in the audience, I'm sure, are very familiar with. This is an incredible driver for many of us, looking at the safety and the destigmatizing of LGBTQ identities and experiences, young people coming out, sharing who they are at younger and younger ages. We are so excited. We'd love to see it. We are thrilled by the younger generations. For those of us in the older generations, I'm a proud member of Gen X. I don't necessarily think that there are dramatically less of us in older generations, but what we do see when we look at this data is a changing set of expectations and norms when it comes to generations. But for those of us in healthcare, we talk a lot about being mindful of older generations still feeling that years of criminalization, stigmatization, shame in healthcare. So we've got some multiple generations sharing new experiences, which we love, right? But the data is clear. Let me hide my polls here for a second. The data is clear. LGBTQ populations report worse health outcomes. We have lower health-related quality of life measurements in every area. We are looking at issues as incredibly important as cardiovascular health, cancer, our sexual health, mental health, issues of violence and victimization. We are off the charts when it comes to that. We know that these disparities are even more pronounced when we look within the LGBTQ community. For those who are bisexual, transgender, and non-binary, these disparities are even greater. We know that LGBTQ competence has very real ramifications. That's why we're talking about it today. Again, I'm happy to share these slides with you at the end of this. You can look up a lot of this important data that drives this work. Really compelling data around 16%. We see these numbers range from 16 upwards of LGBT people who report negative experiences of a discrimination in medical care settings. We know for transgender and non-binary people that those numbers are even greater. These are unacceptable numbers by any measurement, right? Of folks being denied care. We all have our horror stories, either of ourselves or in our community. This culture of trauma that we all are experiencing in healthcare. And again, this fear of discrimination. Whenever anyone talks to us about how do I tackle LGBTQ healthcare disparities, we say we first have to tackle the fear of discrimination, the outright discrimination that we are facing in healthcare. So we brought together some wonderful people to help us think about this. I'm so excited to have our speakers with us. Gaurang Choksi from Join Violet is if you're going to tweet about them, it's Join Violet. Violet is the name of the startup. Check them out. I'll have Gaurang tell you a little bit more about them in a moment. We're joined by Kellan Baker from the Whitman-Walker Institute, David Yu, a wonderful researcher and nurse practitioner here at Penn. Thrilled to be joined by this illustrious group of speakers. So we wanted to start off today by talking about some of the research. David, who's joining us today, a researcher and practitioner, a healthcare practitioner, is going to talk a little bit about his work of looking at the research of LGBTQ cultural competence training. David, I'm going to pass the microphone on to you, and I will drive the slides.
Thank you for the introduction, Jessica. Welcome. My name is David Yu. I use he, him for pronouns. I'm a PhD student at Penn Nursing and nurse practitioner at Penn Medicine. I'm going to briefly talk about concepts of cultural competence and cultural humility and findings of a recent systematic reviews that we conducted in the ADOS about LGBTQ plus cultural competence training for health professionals. So the cultural competence is a concept developed in 1960s and 70s, grounded in the socio-political climates of the civil rights movement. In research, it was originally defined in 1989 by Cross et al. As a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals and enable that system, agency, or those professions to work effectively in cross-cultural situations. So it emphasizes not only individual level competence, but also system level competence. Next. There has been an ongoing debate regarding whether cultural competence or cultural humility is a more appropriate value for health professionals when interacting with culturally diverse groups. Next. The concept of cultural competence has been previously used in the context of race, ethnicity, language, and immigrant or refugee status, and recently expanded to include sexual orientation and gender identity. Definitions of cultural competence have evolved over time. Currently, it is generally defined as the intricate integration of knowledge, skills, attitude, and behaviors that improve cross-cultural communication and interpersonal relationships. This concept has been criticized due to its implication that a provider can master a patient's lived experiences and that there is an endpoint where one is sufficiently proficient. Therefore, cultural competence has evolved to emphasize ongoing engagement instead of terminal training. Next. Also, due to the criticisms, cultural humility emerged in 1998. It is loosely defined as a lifelong process of learning, self-reflection, and self-critique of the interplay of power, privilege, and social context. It has also been criticized, although cultural competence emphasizes the need for a certain level of education and skill, cultural humility highlights ignorance and a willingness to learn. So it says, I don't know everything, but I'm open, willing to learn from patients. As you may expect, it is hard to use as a training framework. Thus, some training programs are named as a cultural competence training, but integrate tenets of cultural humility. Recent studies assert that cultural competence and cultural humility are not mutually exclusive, and each serves a critical role in practice. Next. So there are 3 levels of antecedents for the training: structural, provider, and patient level. Structural factors, including lack of education in curricula and in healthcare settings, and societal stigmatization lead to providers' lack of knowledge and skill, and their biases, stigmatization, and discrimination. These result in patient factors. Also, structural factor and provider factors together create an unwelcoming clinical environment and negatively impact LGBTQ+ patients' healthcare experiences and health outcomes. These eventually lead to the development and provision of LGBTQ+ cultural competence training. Next. This training also has 3 levels of consequences. So as a structural consequences of the training, mandated recurrent training within health science curricula and healthcare institutions enhances health professionals' cultural competence to work with LGBTQ+ clients. These structural and provider levels of consequences create an LGBTQ+ welcoming clinical environment. All these consequences potentially lead to patient-level outcomes, which have not been researched well. Next. I and 3 other researchers conducted a systematic review to examine how LGBTQ+ cultural competence training programs have been designed for and provided to health professionals and how effective they are. We included studies quantitatively evaluating cultural competence or cultural humility training programs for all health professionals. 40 studies were included in the review. Next. As you can see, the studies were conducted in different US regions. The most frequent was the South. Next. Overall, studies had weak study designs and small sample sizes. Many of them were, the training were very short, with an average of 3.7 hours, and mainly used knowledge-based didactic lectures as a single training modality. And there was a lack of theoretical framing for the interventions. Next. In terms of the outcome findings, changes in knowledge were the most frequently measured outcome, and it had the largest effect sizes. Attitudinal changes has the least statistically significant result with the smallest effect sizes. Next. So there are limitations of current trainings regarding design, lack of theoretical framing, weak study designs, small sample sizes, and the tendency to use didactic lectures as a single modality were general limitations of the reviewed studies. Also, in terms of the measurement, limitations included lack of longitudinal assessment and focus on self-report assessment at the individual provider level without patient-reported outcomes. So my presentation is done, and I will get back to Jessica.
David, thank you so much. I just want to sit on this slide for a moment. Again, we're happy to share this and David's upcoming publications that will touch on this. This is really the main piece of why I brought Gaurang and Kellan with us today. I want us to start with these limitations and dive into a little bit about, I want you to introduce yourselves and talk a little bit about how you are individually and organizationally coming at cultural competency training. Maybe if you want to start to sort of center how you're addressing it in new and innovative ways. So Gaurang, why don't I start with you?
Thanks, Jessica. And David, thanks for that walkthrough. Hey everyone, I'm Gaurang. I'm the founder of a startup called Violet. We're based in New York. Personally, I'm really mission driven. I am a gay man. I grew up on Medicaid. And for me, really building health equity has just been an area that I deeply care about. Professionally, spent many years building an insurance company called Oscar. And what I really got to observe at Oscar was our whole healthcare industry needs to really really needs to be built for diverse communities. It wasn't, and now is the time to actually do that. And so at Violet, what we're building is a platform that partners with industry leaders like One Medical, like Northwell, and we really do three things. We benchmark how inclusive clinicians are. So we actually start by understanding who are they and what are the communities they have expertise with. We then upskill them with our own education. David, thank you for that walkthrough. A core part of our education is we actually not just build knowledge, we ask about confidence level. We ask about self-efficacy of, does a clinician feel more confident speaking to racism or speaking to gender in care delivery? And then we also teach with a lot of case vignettes. So we have powerful stories that ask people to reflect based on powerful vignettes that we have through clinical educators that we've partnered with. And then the final thing we do is we recognize clinicians. We really believe that as clinicians are upskilling themselves and becoming more inclusive, that data needs to be really accessible. So right now, oftentimes when people will go to hospital systems or other directories, there is no easy way to say, I want a clinician that's right for me. And here is the communities I need them to have expertise with. And our data is actually answering that question.
Kellan, you're an old timer in this field. Please introduce yourself.
I'm not an exciting startup, it's true. And actually, I'm with Whitman-Walker, which is turning 50 this year. So we've been a longtime leader in the field of LGBTQ health and also working on particularly serving populations of people living with HIV here in Washington, D.C. I'm the executive director of the Whitman-Walker Institute. Whitman-Walker overall is a community health system that seeks to advance both local care for our patients here, as well as to advance knowledge and practice nationally. And when we look at what the Whitman-Walker Institute has focused on, we have three different pillars: research, policy, and education. So in the education bucket, of course, we do a lot of work with direct cultural competency trainings. In particular, we train a large number of community-based organizations here in DC, not just in healthcare, but in other fields as well, recognizing that what happens when people are trying to access services even outside of healthcare, those encounters in areas such as housing, employment, encountering the criminal justice system, those all have impacts on people's health and well-being. But then the two other pieces that we think a lot about are from the research perspective. David, echoing Gaurang's thanks to you for that walkthrough and noting some of the limitations of the evidence base that currently exists around cultural competency trainings. There's, I think, a substantial degree of agreement that these types of trainings are important, but trying to figure out what modalities work best. And then also, to your point, tracking the effects of those trainings, not just on providers, but downstream on their patients. To what degree are patients actually experiencing better encounters and actually having better health outcomes, for example, as a result of being more closely engaged with the healthcare system through a relationship with a culturally competent and trained provider. So thinking about ways of advancing the body of research around what works and how to make sure that we're telling the full story of what kinds of changes does it make for clinicians, and then also what kinds of changes does it make for patients themselves. And then looking more broadly, what kinds of changes might it have for the healthcare system as a whole? For example, are we able to see better health outcomes that mean people are more closely linked with care, that, for example, reduces costs related to preventable health conditions down the road? That's research that still needs to be done. And then finally, on the policy level, trying to look for levers to really institutionalize the practice of cultural competency, both training and its exercise in day-to-day clinical encounters. There's sort of two pieces of this, if you will. One is what I tend to refer to as the hard law, right? So non-discrimination, the requirement that everyone be treated appropriately, or at least not differentially on the basis of particular attributes such as race, ethnicity, sexual orientation, gender identity. And then cultural competency, that piece, that the soft law, if you will, that actually makes the implementation of those non-discrimination requirements possible. But trying to figure out how to institutionalize those in a way such that it's not just the folks who are already interested, who are being exposed to cultural competency trainings, trying to figure out how to make it possible for the entire healthcare system, no matter what people's roles are or how often they see or think they see an LGBTQ plus person, trying to make sure that everyone across the healthcare system recognizes the need to be familiar with the needs of diverse communities, including LGBTQ plus communities, and is actually accessing effective training to institutionalize the appropriate treatment of diverse patients.
Well, I feel like, Kellan, you really got us to this place of wanting to discuss the challenges that we face today. I mean, let's dive into that. Gaurang, how have you seen this challenge that Kellan is saying? How do we get to this institutional level? David's research says that that's a pivotal part of this three-pronged approach, right? We've got provider knowledge, attitudes, and skills. We've got the institutional level, and then how that trickles down into patient outcomes. How do we begin to think about this at an institutional level, Gaurang?
Absolutely. This is something my team and I think a lot about. And Kellan, there was something you said that really hits a nail on the head, which is a lot of times when we offer 10,000 clinicians education on cultural competence, the mission-driven ones, the diverse clinicians will sign up right away. But oftentimes, what is that incentive or that lever that we can actually pull to let others know that, look, this education is for everybody. 1 out of 2 Americans is in the BIPOC or LGBT communities. How do we make sure that every single clinician or care delivery professional knows that as well? Jessica, to your question, at Violet, we're taking a very specific approach, which is we believe that by viewing cultural competence and humility as a skill, we can recognize it and really start creating this circular motion of making sure that diverse patients can always go into a clinical interaction knowing there is safety. So right now, what we're really enabling our partners to do is Violet is an infrastructure platform. So companies like the Northwells of the world, our system partners, they offer the Violet platform to all of their clinicians and care delivery team members. But what the team members are able to know is that not only will Violet provide the quality education needed to upskill themselves, but there is recognition tied to it. Meaning as they're learning and growing, there's patients that know that that clinician is going to be right for me based on my identities and needs.
Right, that recognition, a little bit of a badge system that you've instituted. I guess I'm curious, Kellan, if you've seen, and you've got your ear to the ground, how do we begin to think about this idea of recognizing providers who are doing this work, the systems that are doing a good job? I know we've got our good friends from HRC on the call who do the Healthcare Equality Index. I'm sorry, it looks like our chat isn't working, so I don't think Tari can chime in, but what are some other ways that we can start to work on this lever of recognition for those who are doing the work, right? As I started off by saying, I've been doing this for over 20 years. I don't have a list of all those providers. Where do we begin to think about this?
Yeah, I really think that the recognition is really key, because really it's not about shaming providers, or it's not about saying that providers are doing something inherently wrong. It's about saying that everyone should have the necessary tools in their toolbox in order to understand each individual patient's individual circumstances and be able to feel like they have the tools and the information that they need to be present for that patient and to make sure that they get the care that they need. So that the recognition of clinicians taking active steps to be continuing learners throughout their careers, that's something that's already baked into medicine. The concept of continuing medical education is certainly something that every clinician is very familiar with. And there's no reason to think that cultural competency training should be viewed differently as, for example, continued education in advanced life-saving techniques.
Right.
For example. And so thinking about the pairing of both clinical and cultural competencies and the recognition of the ways that those complement each other, I think is something that we talk about quite a bit in relation, for example, to transgender health, that both pieces of that are very important and they reinforce each other. The degree to which you have clinical competency in working with trans and gender diverse patients that reinforces your ability to be present and to make that patient feel like you're hearing them, that you're able to work with them, you're able to provide them the care that they need. And then gaining cultural competency puts you in that position where you're going likely to see more and more trans patients, both because, you know, as was noted earlier, as you noted earlier, Jessica, changing generational profiles, changing demographics in the United States, and the degree to which our communities are still small and close knit, and people pass word on about where they can go for high quality, affirming healthcare. And so kind of keeping in mind the conversation about that it's not just clinical competency, it's not just cultural competency, it's actually both of them mutually reinforcing each other to make sure that the clinician is able to, if you will, practice at the top of their license, practice at the highest degree of competence that they have, at the highest degree of their skill, and that the patient then has a good experience.
Right.
So I think we're, you know, still looking for the most effective ways to really institutionalize the idea, again, that it's not just one or the other. You know, medical education, including continuing medical education in the United States, is very, very varied. State to state, there's no real ability at the national level to set a uniform platform or a uniform rubric for cultural competency beyond, for example, the class standards, the culturally and linguistically appropriate services standards. But as far as sort of enforcement, it's really up to the medical community itself to identify opportunities, spaces, gaps where this type of training is needed, and to make sure that it's reaching the providers who can benefit from it.
Well, we should talk about the state of education in a second. That's a topic near and dear to my heart. But David, you are an actual healthcare provider on the call who happens to be a member of the community. Talk to us a little bit about, I mean, this conversation that we're having, which is around, you know, what is it like? First off, what did you learn in school? I always love reminding people what did you actually learn about LGBTQ health? You've had many years of training, and then how did you know, what worked for you? You've done all this research, but you are an actual practitioner. What works? What doesn't? Maybe you could talk a little bit about that.
Yeah, from my bachelor's education, actually, I'm from South Korea. And you know, Korea is a very conservative country, and I didn't learn anything when I was in nursing school. Like even in the media, the exposure of LGBTQ content is legally prohibited, so it is impossible to learn those contents in the curricula. When I was in nurse practitioner curricula, I learned very limited contents about transgender health only, and it was maybe at best like 2-hour lecture. There was no practical content, practical skill building sessions. It was just only 2-hour didactic lectures. In the healthcare settings, I also didn't learn anything about the LGBTQ plus health. So whenever I need those contents or those skills, I needed to just educate myself by using other resources. And without motivation, I'm a community member, and I really care about the LGBTQ plus patients. But without motivation or without any desire, it is hard to educate ourselves by using exploring other resources. And I recently also actually published a systematic review about how nursing students are being educated about LGBTQ plus health and well-being. They have very limited or no training currently, and the curricula which have the content, they have a very focused session, just like few hour or just very limited section, instead of broad integration of content or competencies in health, LGBTQ plus health and well-being, which I think the ideal. We should not learn just like few segment or just a few hours of the education about LGBTQ plus health. It just the contents or competencies should be just integrated in the whole curriculum. I think some of the medical education models like that, I think the nursing curricula should be moved toward those models, and it really the learning in the curricula, learning the LGBTQ plus health in the curricula should be prioritized, because sometimes learning in the like healthcare settings have like very limited time and effort, but as a student we are really committed to learning, so that's why it is important to learn and teach in the curricula because of that reason.
Yeah, David, that's a very, very good point. So I just want to highlight something you pointed out. Here you work at a fancy academic medical place. One would imagine you have the time as a practicing, a wonderful nurse practitioner. You are given the time to do continuing education. We're told in academic medicine, that is our key. But you've just revealed that it's even here, it's difficult for you to have the time and the space for more continuing education. And I really hear your call for that at that beginning level of education in nursing, in medicine, and other healthcare professions, because again, you're in that learner state of mind, making sure it's integrated. It gets harder and harder the further out you get. I spent many years thinking about medical education, and I can attest it's very, very difficult. They'll tell you there's not enough. They already have too much to cover already, that it's hard to get it integrated. That one of the challenges, just like you pointed out, do we create separate, moments that we talk about LGBT health? There's some early research that said there were 5 hours in medical education dedicated to LGBTQ health. The majority of that were non-required lunch and learns. The majority of the work, again, what you pointed out, needs to be integrated. So it's an everyday, this is a population that's just an integrated part of it. And the special unique needs are, of course, highlighted, because that's something everyone should graduate, right, from nursing school or medical school, knowing about gender affirming hormones, knowing how to prescribe PrEP, knowing how to do a trauma-informed pelvic exam. So what are we going to do? Kellan, you ready to say something?
Well, I was just thinking about, how important it is, I think, to kind of maintain that balance between identifying LGBTQ plus patients as a specific population that is affected by population level disparities, and where you can perhaps readily identify certain topics that you might want to be more informed about, but also not focusing on the sort of uniqueness, if you will, of LGBTQ plus patients to the detriment of recognizing a common humanity. The degree to which sexual orientation and gender identity are foundational for everyone, just because we don't talk about them as much, or at least as directly, for cisgender and heterosexual people, doesn't mean that sexual orientation and gender identity aren't something that every person has. And so thinking through, the techniques that you could use, for example, around a trauma-informed pelvic exam, that's important for a lesbian woman, for a bisexual woman, for a transgender man, and for a cisgender heterosexual woman in various circumstances, right? There's no reason to think that any one thing that you would learn for LGBTQ plus patient care, either from a clinical or a cultural perspective, is only ever applicable to an LGBTQ plus patient. And so thinking about ways of, again, maintaining that balance of recognizing that there are these specific topics and specific concerns that many LGBTQ plus patients have, largely as a result of their position in social, legal, political power structures in this country, and the degree to which LGBTQ plus people continue to be attacked in the media, on the street, in legislatures, in the courts. So figuring out how to maintain that specific focus on the individual concerns that this population, an LGBTQ plus population, might have, while also finding those points of resonance with broader conversations around cultural competency and the degree to which it's important for any patient to be able to look at a provider, talk to a provider, and see areas of commonality, see resonance. And that's something you asked earlier about work that we're doing at Whitman-Walker around cultural competency. And I wanted to highlight as well culturalcompetency.org, which is a website where we have put together a compilation of best practices informed by work, several years of work with more than 24 experts in cultural competency training, including yourself and a number of folks on the call here today. And so that is really, trying to think through what are the specifics for LGBTQ plus patients, but then also the title of the name of the website is not an accident, right? Culturalcompetency.org. How do you find those points of resonance with all these different elements of patient diversity?
Gaurang, I know that you've seen this in your work a lot.
Yeah, it's a delicate dance, right? Where on one side, what we hear providers and our data shows this, historically, LGBTQ has been lumped into one self-attestation checkbox that they fill out when they join a directory. And when you actually ask them, what is their proficiency working with gender identity, where's their sexual orientation, or even confidence or comfort or self-efficacy, the data shows that lumping LGBTQ into one checkbox doesn't work for clinicians. Whereas on the other side of this delicate dance, Kellan, as you said, how do we keep building really for intersectionality? I'm a gay man, but I'm also an Indian immigrant, and it's really difficult for me to think about one identity triumphing another, especially when I'm trying to find a healthcare provider that's going to be right for me as a human. So it's how do we make sure that patients never feel that sense of, I have to go to this clinician for this identity and this other clinician for this other identity, right?
Yeah. I love this. You're starting to touch on this, and it came up in the Q&A. I saw an audience member mentioned, Gaurang, a couple of your clients. They are a patient for some of the clients that you've just mentioned. And some of this, let's get to some of the challenges. This is a group, we are very aware of the stratified healthcare system in America. There's a direct primary care. You've mentioned a couple of those companies. There are self-funded corporations. There are publicly available plans. Most of us are tied to our employer. We might change every year. I might go from one PPO to an HMO. And how do we start to address this? Kellan, what does the cat say about all of this? Cat care.
Opinions.
Full of opinions. Let's dive into the sticky widget of this work, which is how do patients navigate this when our coverage changes, our providers change. We're talking so much about the individual relationship with a provider, but I'm really at the mercy of so many other systems. Who wants to tackle that widget?
I can take a stab, and I'm a little biased given what we're building at Violet, but I deeply believe that we need an infrastructure solution. What I mean by that is we know that 1 out of 2 Americans gets healthcare from their work or employer care, sponsored care, and the other 1 out of 2 is on Medicare, Medicaid, uninsured, or on CHIP or other programs. So what we really believe, and I believe this deeply having grown up on Medicaid, is regardless of where people are getting their insurance, we need technology to help people get to a clinician that's right for them in their network, where that data and that infrastructure layer can actually help everybody. So I actually think the industry needs to coalesce, including hospital systems and health plans and employers. And that's asking a lot, but it's that infrastructure solution that can really be an answer. The other side of that, it means we really just have to show where the dollars are, right? We live in a capitalistic healthcare system, and we need to show that if you build better relationships, people get better faster, and somewhere that reduces costs or makes somebody else money.
There was just an article this morning in the New York Times, my former primary care doctor. The conversation is about how do we pay and charge for emails between providers and patients. The kind of level, I live for those emails, right? As someone who barely left the house in 3 years, I've been living by email with all of my healthcare providers. So the idea that this is now up for a conversation about either limiting that or creating that into a chargeable moment is harrowing. How much of that, again, that relationship building. It's already, as a queer person in medicine, going into healthcare, I've got so many boundaries up. I've got so much fear and anxiety. Am I going to be treated with respect? Are you going to understand my unique needs? And then I met with all of these other issues. Kellan, how are we knitting this together? Whitman-Walker has been serving the public for 50 years, doing what others wouldn't do. We learn from them. What are some answers of knitting together this fabric that Gaurang is highlighting when we're bounced around? What's the infrastructure answer to this?
Well, two of the unique aspects, if you will, of a place like Whitman-Walker is one, well, not specifically only unique to Whitman-Walker, but strengths that we bring, for example, as a federally qualified health center, are one, a focus on primary care, really trying to focus on ensuring that there is no wrong door when people are coming for any type of service, that they can then get pulled into a broader wraparound set of services that have their basis in primary care, in a health home. Whitman-Walker is a patient-centered medical home. It is the kind of place where the sort of holistic appraisal or understanding of where patients are coming from and what they need can live in one place. There's a lot, as you noted, of fragmentation, and we struggle with that when we have to refer patients out because of the way that our healthcare system is set up. Places like Whitman-Walker that focus on primary care aren't really supported to do secondary, let alone tertiary care. And I think so trying to figure out how to knit the practices, the clinics, the healthcare organizations that really focus on primary care, how to amplify the importance of that. We're so accustomed in the US healthcare system to paying top dollar for really high-tech medical interventions and breakthroughs, and that's wonderful. But also the foundation of health and well-being over the life course is primary care. And so, but in the United States, we have very seriously devalued that. We're much more likely to focus on highly specialized care that is incredibly important and is one of, I think, the great legacies or enduring contributions of the United States to the global conversation about healthcare. We do a lot of things really well here in the United States, but unfortunately, that doesn't include prevention. And it doesn't include primary care. And so trying to figure out how to elevate the importance of primary care as a place where somebody has a health home and amplifying or strengthening the bonds between primary care sites and other types of levels of care that people might need. The second thing that a federally qualified health center does really well is seeing people regardless of the ability to pay. There's this really unfortunate idea in the United States that other ways of paying for healthcare or organizing healthcare are rationing, right? That there's, if we have some sort of role that's larger for government to make sure that more people are able to access healthcare, that's somehow going to ration care in ways that aren't happening now. But care is rationed in the United States. It's rationed by income. And so the inability of so many people to access really vital healthcare services means that we're not serving patients who really need healthcare. And that means also that they're locked out of the types of encounters with clinicians where a broader swath of the clinical workforce would recognize the diversity of the US population as a whole, right? Recognizing that there is actually, in many ways, a distinction between what the US population looks like versus what any given healthcare organization's patient population looks like. And recognizing the ways in which poverty is racialized in the United States, it is unequally distributed by geography, by immigration status, by primary language, by sexual orientation and gender identity. And so trying to think about ways of expanding the ability of any person in the United States, regardless of their income, to access the healthcare that they need at multiple different levels, primary care, secondary care, tertiary care, I think is another thing that has the potential to knit more closely together our clinical workforce in understanding the importance of seeing the full spectrum of diversity, not just of a small group of patients that they might see, but of their broader communities and of the US population as a whole.
One could really imagine the influence of those great primary care settings influencing that referral network, right? That's sort of how we think of it, and how much other specialists can learn. If that is, I know that's something. I think that's a beautiful point that you've just made. One of the comments that's coming up from the audience is, so if you're not a provider, they're not CEOs on this call, how do regular patients, and I think this is a wonderful way to spend the last couple minutes of this webinar talking about the overall challenges. We picked cultural competency of healthcare providers as one of the levers that we think is very vital to addressing the healthcare disparities of LGBTQ populations. Let's, all three of you, I'd love to talk a little bit about the other challenges that face the healthcare system, as well as this challenge, and how can the everyday people who are on this call advocate for change. So there's people saying, how do I advocate at my institution for more culturally competent care? How do I make it clear that this is important to me when I'm just a small part of this cog in the wheel? David, do you have thoughts about, you work inside of a massive healthcare system. How can patients play an advocacy role of asking for this kind of care or helping to address some of these challenges?
I think that the culturally competent healthcare cannot be created and then complete without community voices and then patient voices. I encourage as an LGBTQ plus community member and patient myself, whenever possible, if healthcare facilities or individual provider would like the patient's voices, feedback, comments, or opinions to innovate their systems, policies, or practices, I want them to speak up. As we all know, the first step of the problem solving is to define the problem. Sometimes, as a provider or as a healthcare institutions, without explicitly being told by other people, they may not recognize what the problem is.
Right.
And also the power dynamic between the provider and the patients cannot be broken completely when both the provider and the patients are trying to break. And it's not only it's important to for the provider to acknowledge they have power privilege and their willingness to break, but also it needs to be done from the patient's perspective as well. Like, don't be just passive. Be an active patient, advocate themselves and speak up for their optimal decision, medical decision making. That's why we call the shared decision making. So it is important as a patient, even though it's just one patient, it is really important to make their raise their voice, to be a just integral part of the healthcare system. They're not just patient; they are really integral. Without patient, the healthcare doesn't exist.
Right.
Because
right.
As an integral part of the healthcare system, I really want them to raise their voice.
Yeah, it was another comment just came in through the Q&A. Folks asking, it sounds like it's someone from outside the U.S. asking if there's a confidential way to disclose moments of discrimination in the healthcare system. And I think I want to thank you for raising that. I think this is, again, we're trying to cull, what next steps do we need to take after this webinar? I think thinking about that feedback loop that David's mentioning, some of the surveys, some of the ombuds offices that exist inside of hospital systems are really vital to use. I know for many of us in the LGBTQ community, we can be exhausted by having to tell our traumas over and over again. But for those who are able to do it or are able to give feedback, we need to start to think a little bit more about these feedback loops. Gaurang, do you want to talk a little bit about that?
Yeah, I was frankly going to share a similar narrative as David. Honestly, share your stories. Share your stories with care delivery organizations, hospital systems where you felt like the care wasn't good enough, or somebody is doing something where they may not have known that they're being discriminatory, but if they are, share that story. And I know, Kellan, you mentioned class standards. I added the link in here. Write to politicians. Let politicians know that, look, cultural competence education should be mandatory. We want people to be inclusive, especially given how much we spend on healthcare. And let's make that a normality across the board.
Mm-hmm. And I would add, if you receive your health insurance through your employer, speaking up to your office, your HR people, those are huge contracts. They spend a lot of money on it. And it's vital to say, hey, I get health insurance through you and I can't find a provider that I can feel safe with, that knows about my unique needs. Hi, we're making babies. I need my coverage to include that. I love, holding our employers who pay so much money for these products, have the ear of the Cignas and the Humanas of the world. So it's wonderful to, again, think about where are those places where, again, not to keep re-traumatizing ourselves, but where can we start to let our voice be heard and start to feel some of that self-advocacy in a positive way. Kellan, the last couple of minutes here, you are our DC insider. You're sit in the belly of the beast. What can we do to be helpful in moving this needle?
No small task. That is, I think it requires all of us thinking together, because as we discussed earlier, there are limits. One of the outcomes of the way that we've set up our government in the United States is that we don't actually have a lot of levers from the national level. It really does come from local action within individual practices, within individual hospitals, medical systems, insurance carriers, to really try to work one-on-one or at smaller levels than even a state or let alone a national level, to say this is really important. There are LGBTQ plus people everywhere. That's one of the things that we've seen from the admittedly limited data collection that we still have on LGBTQ plus populations in the United States. There are LGBTQ plus people everywhere. And so there's a lot that we can do as individual engaged consumers, to the points that folks have already been making. If you encounter discriminatory treatment, or if you know someone who has, then taking that step of writing a letter and not assuming that anything is too small to raise to a level of attention. Also looking for those opportunities for feedback loops. We talked, Gaurang, you talked quite a bit about the work that Violet is doing to encourage providers to gain additional training and cultural competency and working with LGBTQ plus patient populations. And so then looking for what are some of the ways that we can then connect the patients who need that information about where those providers are. And I know, GLAMA, I'm going to get the new name. I suppose it's not new anymore. Health Providers for LGBTQ plus Equality. I got that wrong.
Can I get somebody to drop my favorite link in the chat? One of my staff members. Is it this? Did I get it right?
There we go. Yeah. There we go. Health Professionals Advancing LGBTQ Equality. Yes. Yes. Has really been doing a lot of work to try to that really critical link of, once we get the providers trained and once we get the patients, prepared to expect better, how do you actually do the matchmaking, make it possible for people to look things up? I don't want to be the last word here, so I'll just say one last thing, which is, you can't have me anywhere without me talking about data collection. So one thing, for example, we are working very hard to get sexual orientation and gender identity demographics included in some of the big national surveys that do actually look at patient experience. The CAPS survey, for example, which assesses the degree to which people felt respected and listened to by their providers on the basis of attributes such as race, adding sexual orientation and gender identity in there, looking at measures such as HEDIS, the performance measures that are used by a lot of health plans, to try to get a better sense, not just on an individual patient level that we can report the experiences that we've had, but so that these national or these large data sets actually have sexual orientation and gender identity included, so that we can look at the differential experiences that people are having on a population level. So I guess that is just to say, if you see a survey asking about your experience as a patient, don't just throw it away. Fill it out and write a little note somewhere. Let Press Ganey know. Let the Agency for Healthcare Research and Quality know. Let whoever it is that's asking you, that's surveying you about your experiences, let them know that it was great, it was terrible, and we really do want you to know more about LGBTQ plus patient populations and experiences in particular.
Yeah, we measure what matters. And Kellan's work, I know, around SOGI data collection, it's vital. Again, the trickle down effect, it tells everybody this is what matters. I hear all the time from healthcare providers and leaders, well, the federal government doesn't ask it, so it must not matter. We take our cues at the highest levels. And so we really are looking for, at all levels, for people to raise the bar on standards of care, to raise the bar on the questions they're asking, to be the first. I will wrap up by saying we've got folks in the Q&A. I just want to say thank you. People have been called in from all over. People, especially I want to give a shout out to, there's been quite a few nurses and nursing students in the chat who have been alarmed and frustrated at the lack of education that they're getting in their current curriculum. We're excited to try to tackle that. Again, what you heard today were a lot of calls to action, thinking about how we educate providers from the beginning, how we make continuing education more of an institutionalized, celebrated moment, continual learning, that shared decision-making. But I want to end with truly asking all of us to think about ways that we can be involved, whatever sector you're involved in, right? If you are in any of the sectors that we're here today or others, there's a role to play about telling your story, speaking up, letting people know that you're there, that it matters to you, and that you'd like to see folks do better. So with that, I will thank our guests for our wonderful Zoom here today. Check out joinviolet.com. It's a fascinating platform. Check out Whitman-Walker. The website is in the chat. We will share that also later. Again, if you're a cultural competency trainer or you're thinking about it, Whitman-Walker's got some guidelines for us. And David, we will be sharing your research. We can't wait for you to finish with your PhD